teacher. I'll be speaking on a subject that is very relevant in the present scenario where we have intravitreal injection as the most common surgical procedure that is done in any surgical theater. And these are some of the common indications for which intravitreal injections are given: retinal vein occlusion, non-ischemic vein occlusion, neovascular age-related macular degeneration, myopic CNVM, diabetic macular edema, and proliferative diabetic retinopathy. So we will deal with both intraocular pressure elevations after the use of anti-VEGF agents and also the use of intravitreal steroids. If you look at anti-VEGF agents, the IOP pressure elevation can broadly be classified into two: the prompt post-injection elevation in intraocular pressure and the sustained IOP elevation. The transient post-injection IOP elevation occurs in the immediate post-injection period and the pressure returns back to normal within 30 to 40 minutes, while sustained IOP elevation due to various reasons occurs in the post-injection phase, varying between 14 weeks to 7 months after injection, and the pressure may rise more than 26 millimeter of mercury, and there may be a difference of more than 6 millimeter between both the eyes. If you look at the factors responsible for the prompt and immediate elevation of intraocular pressure, in majority of these patients, the pressure returns back to normal in about 15 to 30 minutes time, and hence no specific treatment is necessary for this condition. However, there is some concern whether the volume-related increase in intraocular pressure may further damage the ganglion cell layer or the optic nerve head in an eye which is compromised. For example, you're dealing with a patient who has a primary open-angle glaucoma. And there is also concern whether protein paracentesis should be performed in all these patients, and does this patient require IOP monitoring till normalization of pressure. If we look at the volume-related transient elevation of intraocular pressure and the mean ocular pulse pressure, you will see from the slide here that there is a sudden drop in the mean ocular pulse pressure immediately following the injection. This usually translates to a decrease in the juxtapapillary perfusion pressure by about 7.4% for every 10 millimeter rise of mercury pressure. And also it translates to an increase about 8.4% reduction in the optic nerve head perfusion in this transient period of time, but the IOP is very high. However, the very efficient autoregulatory mechanism present in the optic nerve head and the peripapillary retina ensures that there is a compensatory decrease in the optic nerve head vascular resistance, which takes care of this transient decreased mean ocular pulse pressure. So we are safe unless we are dealing with an eye which is already compromised with primary open-angle glaucoma and has extensive optic nerve head damage. If you look at various factors which correlate with the increase in this baseline intraocular pressure, a positive correlation is noted between the short-term IOP elevation and the baseline IOP, between the number of injections, the frequency with which the intravitreal injections are given. There was some concern whether injecting in a small eye with the hypermetropia would cause a prompt elevation of intraocular pressure, but several studies have very elegantly proved that this is not so. The most important correlation is between the gauge of the needle that we use for injection and a phenomena called the post-injection reflex, or the PIR. The post-injection reflex is actually a very good safety valve mechanism which ensures that the pressure does not go up in the post-injection phase. But for the surgeon who is injecting for the first time to see liquid vitreous and some amount of the drug that we have injected into the eye come out, it is a little frightening, and most of us tend to press on to the reflex. Here in this video, you see the post-injection reflex, and we have the natural tendency to press onto the reflex. If you are using a smaller gauge needle, like a 30 gauge or a 32 gauge needle, there will not be any reflex, and the IOP tends to be transient elevation of intraocular pressure tends to be on the higher side. If you are using a tunnel entry into the eye, also the PIR will not be there. Where if the full depth of the needle goes into the vitreous cavity and you're injecting into the middle of the vitreous cavity, there is less chance of fluid effluxing from the eye. And if you're injecting slowly, you give time for the eye to adjust so that the PIR is not there. In all these situations where a post-injection reflux is not there, the chance for a high transient post-injection elevation of IOP is present. Pre-injection compression of the globe by using the enhanced pressure reducer or even the pinky ball that we routinely use in cataract surgery has no effect in the transient elevation that is seen post-injection. Pre-injection prophylactic treatment with topical or systemic anti-glaucoma medication also was not found to have a role. The single important procedure that reduced the transient elevation of intraocular pressure was performing a paracentesis, and this is necessary in eyes which already have pre-existing glaucoma, especially if there is disc damage and visual field loss. However, this procedure carries an additional risk of iatrogenic injury in about 0.7% of subjects. So is a paracentesis necessary in all patients who undergo intravitreal injection? It may be necessary because if you are already dealing with an eye which has a compromised retinal microcirculation and a broken red blood retinal barrier, especially if you are dealing with an eye with a diabetic macular edema or retinal vein occlusion, and by performing a paracentesis, you let out about 210 microliters mean amount of aqueous, which reduces the intraocular pressure. It also prevents a PIR and ensures that the full load of the drug that you intend to inject into the vitreous cavity remains within the eye and takes care of the macular pathology. Therefore, prophylactic lowering of the IOP medications is not necessary for the treatment management of the transient elevation of intraocular pressure, nor do you require monitoring of the patient till there is normalization, except if you are dealing, as I said already, in a patient who has an advanced glaucomatous optic neuropathy. Now let us look at sustained IOP elevation, which has several definitions, several criteria to cause it a sustained elevation. And this is what we use in our center, an IOP elevation of about 25 millimeters of mercury, or when there is a +5 millimeter rise from the baseline intraocular pressure on 2 consecutive visits. And you see that this is present for more than 30 days. The onset is between 14 and 7 months. If you look at the incidence of sustained elevation of intraocular pressure, there's a vast difference between what we see in the real world settings. And if you look at the post ad hoc analysis of the randomized controlled trials, if you look at a combination of both, the incidence is about 8.3%. The postulated risk factors for sustained elevation of intraocular pressure are an increased duration of treatment, which in turn translates to an increased number of intravitreal injection and the presence of pre-existing glaucoma. There is no role with respect to the type of drug that we use. That means there is no role whether we are using ranibizumab, bevacizumab, aflibercept, or brolucizumab, or the protocol that we follow, whether we are doing giving therapy on a fixed monthly injection basis or giving the loading 3 dose and following a PRN basis or a treat and extend concept. Whatever is the protocol that you follow, it has no specific effect on the sustained elevation of intraocular pressure. Let us look at this example of a patient with a non-ischemic central retinal vein occlusion and macular edema who received 3 injections of Lucentis. His baseline IOP was 20. At the end of 3 injections, it rose up to 24 millimeter of mercury. We followed him up with fields and RNFL analysis. Since there was no progression, we just kept him on observation. So we cannot call this a sustained elevation of intraocular pressure. This is another example of a patient with a diabetic macular edema who received 3 injections of Avastin. He is not a known case of primary open-angle glaucoma, nor does he have a family history of glaucoma in any of his relatives. The IOP was elevated from baseline by 10 millimeter of mercury. He has a central corneal thickness of 575 micron. There were no associated field changes or RNFL thickening. We put him on brinzolamide eye drops to reduce his intraocular pressure and also to help resolution of his macular edema, and kept him under follow-up. Let us look at the factors that are responsible for development of a sustained elevation of intraocular pressure. The most important is the microparticle obstruction of the trabecular meshwork and some amount of trabeculitis. The keratic precipitates have been demonstrated in the trabecular meshwork in patients who receive intravitreal injection. And what is this monomer that is blocking the trabecular meshwork? There are very elegant microflow imaging studies which have shown that the microparticles or the subvisible particles increase in density as the whole time of the drug increases. For example, if you are using Avastin and you keep it for a period that is greater than 14 days, you see that the number of microparticles increase, and these microparticles contain basically silicon micro droplets leached from the plastic syringes or protein aggregates from medication packaging and delivery. the longer storage of these drugs in plastic syringes, multiple freeze-thaw cycles, especially if you're taking the drug from one clinic to the other, if you're practicing in multiple centers and using the same vial in different places, all this will predispose to the increased presence of microparticles, which can clog the trabecular network. This is smoked with prefilled ranibizumab and repackaged bevacizumab. The anti-VEGF that we use by itself is toxic to the trabecular meshwork cell by disrupting the nitric oxide pathway and inhibiting the action of nitric oxide synthetase. And we all know that nitric oxide is necessary to improve the facility of aqueous outflow. And hence, this has a definite toxic effect of the trabecular meshwork cell. There are definite VEGF receptors which are present in the wall of the Schlemm's canal, which are necessary for improving the facility of aqueous outflow. The anti-VEGF agent, because inhibition in the action of these of the VEGF produced in the trabecular meshwork, and this may be responsible for the decrease in the outflow facility that is seen in patients who are on chronic anti-VEGF therapy, and the reduction in the RNFL thickness which is associated with this condition. A significant reduction in RNFL thickness is noticed mainly in diabetic patients on treatment for diabetic macular edema. If you look at the molecule size of the various molecules that we inject into the eye, the bevacizumab has the largest molecular weight, and it has both the FC and the FAB segment of the monomer, and it can bind 4 molecules of VEGF. Everything together, it forms a paper doll or a daisy chain pattern, which is quite a large conglomerate of monomers, and this can theoretically clog the trabecular meshwork, but in actual practice, we do not see any difference between whether you're using ranibizumab, bevacizumab, or aflibercept. So this is our patient again who has recurrence of the macular edema. What will you do? Will you inject drug? He requires another injection. He has an elevation of intraocular pressure. You can still inject. Making a note that sustained elevation of IOP was present in his case sheet. Consider anterior chamber tapping or paracentesis before injecting. Consider stepping up his anti-glaucoma medication. Follow him up closely with repeat fields and RNFL analysis on a monthly basis. We'll look at shortly on the role of steroids in causing an elevation of intraocular pressure. These are the various steroids that we inject intravitreally, and the risk factors can be classified into drug-related and ocular risk factors. The ocular factors are very important and is more commonly seen in primary open-angle glaucoma suspects, patients who are first-degree relatives of POAG patients, type 1 diabetes, high myopia, in extremes of age, and in a patient who has been a prior steroid responder and his pressure has raised more than 50 millimeters from the baseline. This is a patient who is a known primary open-angle glaucoma patient on Lumigan for the past 3 years. He has a risen myocardial infarction, which indicates that he is not a good candidate for anti-VEGF therapy. His baseline IOP is 18 millimeters, controlled with Lumigan. His central corneal thickness is 538 micron. Post-injection IOP is about 8 millimeter from the baseline, and there is an 8 millimeter difference between both the eyes. We step up his anti-glaucoma medication, adding brinzolamide. There is no further progression of the RNFL or field changes, and we keep him under regular follow-up. The requirement of surgical management or topical anti-glaucoma medication following use of topical steroids is given here in this slide, and the maximum pressure elevation is seen with fluocinolone implant. We commonly use the dexamethasone Osidrax implant, which has less tendency to rise the intraocular pressure. So do not take a single high reading of intraocular pressure post-injection as an index of risk. Compare the pressures between both the eyes, look at the difference in IOP, look at whether there is a asymmetry in the cup-disc ratio, correlate your intraocular pressure with the pachymetry readings, and then come to a conclusion as to whether your patient requires treatment for the elevation of intraocular pressure post-intravitreal injection. Steroids can cause elevation of intraocular pressure by several means. It causes increase in the extracellular matrix of the trabecular meshwork. It causes accumulation of glycosaminoglycans, and which causes a physiological, a biologic edema, clogging the trabecular meshwork. In addition to that, it causes stiffness of the trabecular meshwork cells by increasing the number of cross-linked actin network, and the extracellular matrix that is seen is also much stiffer. So we have stiffer trabecular meshwork cells, a stiffer matrix, which could be responsible for an increase in intraocular pressure caused by steroids. In addition, steroids also cause inhibition of the phagocytotic properties of the endothelial cells. So we have a lot of debris sitting there at the trabecular meshwork. There's a decrease in the synthesis of prostaglandin, which could dysregulate the aqueous outflow. Steroids also cause apoptotic death, as indicated by the increased expression of LDH enzymes and the presence of genetic materials, the FOS, JUN, MYC, and the P53, as well as caspases, which are released into the trabecular meshwork after triamcinolone acetonide injection. So here's a patient again who has got recurrence of macular edema, and would you consider putting in a second oxydrasine blunt in his eye? We take faith from the study called the Shasta study for macular edema and retinal vein occlusion, which dealt with 289 patients. 15% of them had no history of response to steroids. 30% were diagnosed primary open-angle glaucoma patients and were on IOP-lowering drugs. The results of the study showed that these patients received more than 3.2 implants. However, the glaucoma was definitely manageable either with medical therapy or with surgery. So in conclusion, the steroid implant-induced glaucoma is a manageable condition, and we should consider intravitreal steroid injection if the condition of the patient deems that it is appropriate to use steroids. We should look at the visual outcome and not the IOP, which is the final arbiter of the decision-making process. I thank you very much for your patient hearing.